Good afternoon, everyone. Welcome to today's webinar. I'd like to welcome everyone to this webinar, which is hosted by Hepatitis United, which is a national coalition co-chaired by my organization, the Hepatitis B Foundation, and the Association of Asian Pacific Community Health Organizations, or APCHO. Well, Hepatitis United is a national coalition working with stakeholders toward the prevention and elimination of hepatitis B in the United States. My name is Kate Morars. I am the Senior Program Director at the Hepatitis B Foundation, and I will be your moderator today. Before we get started, I'd like to remind all participants that during today's webinar, you will be in listen-only mode. If you encounter any technical difficulties online with your computer audio, please dial in using the phone option on your control panel, and the conference numbers are shown here. At any time during the presentation, if you have questions, you can also enter those questions into your control panel question box. Questions will be addressed by the speakers at the conclusion of the webinar. If you have any technical challenges, please also indicate that in the question box. And this month, we are holding this webinar in recognition of Liver Cancer Awareness Month. During today's webinar, we'll be discussing the link between hepatitis B and liver cancer. Our panelists will discuss liver cancer and its risk factors, the Centers for Disease Control and Prevention's National Comprehensive Cancer Control Program, and promising state-based initiatives and strategies for liver cancer prevention, which includes the Hep B vaccine, awareness, and provider education activities. We'll also be hearing from a patient advocate who will be sharing a personal story. And I'd like to go ahead and introduce all of our panelists today. Our first speaker will be Dr. Banush Momin, who is with the CDC Division of Cancer Prevention and Control. We'll then hear from Ms. Charlene Carriot, who is the Health Program Manager of the Comprehensive Cancer Control with the Idaho Department of Health and Welfare. And we will conclude with remarks from Dr. Jacki Chen, who is part of our Just Be storytelling campaign and a patient advocate. And I'll begin with sharing the video from our Just Be storytelling campaign, which is an initiative that the Hepatitis B Foundation started 3 years ago. The Just Be storytelling campaign aims to increase awareness about the hepatitis B, encourage testing, and combat stigma and discrimination. Sorry, one moment. I'm going to ask my colleague, Catherine, to share the video from her screen, which is in the control panel. If you hit show and then, actually, you can show it from the control panel. You hit show and then the video should be loaded. Great. Thank you so much. And we hope you enjoyed Jacki's video. Jacki will be providing some remarks after the presentation. And I'm now going to turn the presentation over to Dr. Banush Momin and Ms. Charlene Carrier.
Thank you, Kate, and thank you to all for joining this afternoon's webinar on national and state initiatives to prevent hepatitis B and liver cancer. My name is Banush Momin, and I'm tag teaming this afternoon's presentation with Charlene Carrier, who's the Health Program Manager at the Comprehensive Cancer Control Division of Public Health in the Idaho Department of Health and Welfare. We have 5 key objectives for this presentation this afternoon. The first 2 are ones that I will hope to address, and those are to provide the audience with the background on liver cancer and its risk factors, as well as describe the priorities of CDC's National Comprehensive Cancer Control Program. And then Charlene will step in and share some of the type of liver cancer interventions that have been implemented by the Idaho Comprehensive Cancer Control Program, along with sharing how each of these interventions implemented were evaluated to inform future implementation efforts. And she will end with discussing some lessons learned, program needs, and partnerships that were created, as well as program facilitators, challenges, and some key resources that were needed in her implementation efforts. So a little bit of background. Earlier this year in May, the annual report to the nation was released, and it was reported that from 1999 to 2016, overall cancer mortality declined. However, the annual number of new cases in the U.S. with respect to liver cancer increased. In 1999, the age-adjusted rate of liver cancer cases was 4.9 per 100,000. And if you fast forward to 2016, which is the latest data that we have available, the rate is 8.3 per 100,000. So looking at the time period from 2006 to 2015 alone, the incidence rate increased by 32% and the death rate increased by 25%. And the next couple slides highlight some of the data that I just shared in terms of the annual number of new cases as they're on the rise with respect to liver cancer. Now, who is it primarily affecting? So the incident rate varies by race, ethnicity, and sex. Males have a 3 times higher incidence rate than females.
Banush, I believe we might have lost your audio. Maybe you can try muting and then unmuting yourself again. Sorry, everyone. We'll pause for just one moment while our speaker tries to reconnect to the webinar. Banush, you may want to try to switch to your computer audio if you're on your phone, or vice versa. We still cannot hear you. So why don't we, Charlene, should we switch over to your presentation? We'll swap. We're going to switch over to Charlene's presentation, and then we'll come back to Banush when Banush reconnects to the webinar. Apologies for the technical difficulties, everyone. So Catherine, if you'd like to, if you could advance to
slide 34. All right, hi everyone, my name is Charlene Cario, and while we skip through all of this really great background information that would give you a little more insight into what the comprehensive cancer control programs are, I'm just going to dive in and let you know what we did here in Idaho. So again, my name is Charlene Cario, and I am the program manager for the Comprehensive Cancer Control Program here in Idaho. If you could skip forward a few more slides, it'll have my logo on it. Yep, there we go, perfect. And I think I will get control of the slides as well. So the Comprehensive Cancer Control Program had the opportunity to participate in a pilot project with the Centers for Disease Control back in 2017. So I was able to get involved in this project when the CDC reached out to the cancer control programs around the country that had specifically listed liver cancer as part of their comprehensive cancer control program. So I was one of the handful of states, or Idaho, not me. Idaho was one of the states who had liver cancer work specifically listed in our comprehensive cancer control plan. So we were able to participate with CDC on this pilot project. So for those of you who are, oh, and I still don't have control of the slides.
Charlene, this is Banush. Can you hear me?
I can hear you.
Okay.
Yep. So we'll just jump back to you once we go through these, if that's okay.
Sure.
Okay. All right. So the Comprehensive Cancer Control Program, and this is true for most comprehensive cancer control programs around the country, the program specifically focused on preventing cancer, increasing cancer screenings, and then creating increasing quality of life for cancer survivors. So specifically here in Idaho, we're guided by not only national goals related to cancer control, but also our statewide comprehensive cancer control plan. And through these efforts, we hope to be able to reduce cancer risk, decrease mortality, and improve the quantity and quality of life for cancer survivors. So when we were contacted to participate in this project, Idaho's liver cancer rates ranked 9th for mortality with a rate of 5.3 per 100,000. And as of 2016, which is the latest year final data is available for, liver cancer has moved up a spot to become the 8th leading cause of cancer death in Idaho with a rate of 6.6 per 100,000. So as a program that focuses on prevention and risk reduction efforts, we wanted to focus on increasing the hepatitis B vaccination. And unfortunately, Idaho's not super great with our vaccination rates. So in Idaho, the birth dose of Hep B was well below not only the Healthy People 2020 vaccination goals, but also our statewide comprehensive cancer control plan goal of 85%. So lots of work to do, and our program really chose to focus on that Hep B birth dose. So in order to accomplish this work and as part of this pilot project, we expanded our partnership with our statewide immunization program. So we had initially started some work with our immunization program on HPV vaccination, and thanks to this work, we were really able to solidify that partnership by focusing on hepatitis B vaccination as well. And in many states, the cancer program and the immunization program are in different kind of organizational structures within statewide departments of health. So even though it seems like, oh yeah, of course, public health programs all work together, sometimes that's not always as intuitive or easy. So we were able to really solidify that partnership here in Idaho. So again, the focus for our pilot project was really on the hepatitis B vaccine as cancer prevention. So from August of 17 to December of 2017, we really focused on educating parents about the hepatitis B vaccine as a cancer prevention method, and then educating healthcare providers about the importance of them making a strong recommendation to vaccinate their patients, specifically around that birth dose. So the strategies that we chose to use here in Idaho, we focused on social media campaigns to provide education to parents. And then in the fall of 2017, we worked with our immunization program to host educational sessions around the state. So the immunization program was already hosting something that they called booster shots, and that was their kind of mid-year check-in with vaccine providers around the state. So we were able to attend and participate that and take over some of that agenda to talk about vaccine preventable cancers. And then we also did a lot of really great tailored social media efforts. So from August to November of 2017, the cancer and immunization programs posted hepatitis B and liver cancer prevention content on our respective Facebook pages. And these posts were planned and organized via kind of a pre-developed social media content calendar that we shared between the two programs. And we were able to specifically target our priority population of new or potential parents through boosting and doing some paid content advertising specific to liver cancer prevention work. So on the next couple of slides, I'll show you some examples of what that liver cancer prevention campaign looked like. So we worked with a marketing firm to help design some of these materials. So we really wanted to focus on kind of happy, healthy, positive, reinforcing messages. So lots of cute babies, lots of happy families, lots of prevention messages. And we were also able to take that material and develop a quick little 30-second video that I'll make sure to share with the organizers so we can get that posted out to all of you if you want to take a look. But it's a quick little 30-second video that highlights the current state of liver cancer in Idaho and how great and easy the vaccine is for preventing it. So we were able to evaluate our prevention campaign efforts using data from Facebook Insights. So if any of you have ever done any social media campaigns, there's some really great kind of built-in measures that you're able to use to help evaluate your work. So we were able to evaluate the total post reach of every post that we shared, how many of those people were reached just through kind of organically coming across that post, and then also how many folks we were able to reach through our boosted campaigns, which were which were paid advertising. For our healthcare presentations, we were able to evaluate participants' change in awareness, knowledge, and ability to implement some of these liver cancer prevention strategies. And I'll share a little bit more of that data in a few slides. So between the immunization and cancer programs, we shared 32 liver cancer and Hep B specific posts on our respective Facebook pages. We found that photos were definitely better received. So of those 32 posts, 28 were videos, 28 were photos, and then a handful were links and a video as well. Between all of these posts, we reached almost 44,000 unique users, which is great. Of those users, we reached a little over 11,000 of them organically, and then through our paid posts, we were able to reach over 31,000 users, which was really great. We also, in addition to our social media campaign, we had some print materials as well. These were available to order online, and we were able to share these resources at the booster shots educational sessions at an informational table. Our provider education presentations occurred around the state of Idaho. So for those of you who aren't familiar with the state, we've got some pretty distinct regions, and they're all kind of geographically unique and different. So we reached almost 300 attendees. All of these folks who were in attendance were related to vaccine administration, coordination, et cetera, in some way. So they were either medical assistants or nurses or providers in a clinic, or they were managing, kind of ordering vaccines and making sure they were stored appropriately. And we hit kind of the major regions around the state with these presentations. The data for these provider education presentations are really exciting to me. So we did a pre and post-test intervention for these measures on the screen at each of the educational sessions. And what I really want to highlight is through these booster shots presentations, they led to positive changes in awareness, knowledge, ability, and intentions related to administering the Hep B vaccine. And the greatest pre-post changes occurred in awareness of liver cancer rates in Idaho, the relationship between the hepatitis B vaccine and preventing liver cancer, and the resources available to help them educate their patients. So seeing this data was really encouraging that we were on the right track. So like any good public health program, we obviously wanted to evaluate our efforts for this pilot project. So as mentioned in previous slides, the program measured success as it relates to increased knowledge, awareness, and intention, to increase vaccination among health care providers through our booster shots event evaluation. And we measured the reach of our efforts to the general public as well. Some of the things that really helped this project kind of cruise along and, in my opinion, be successful, we were able to have the cancer and immunization programs work together fairly easily. So we're both housed within the Division of Public Health here in Idaho, and even though we are in different bureaus with different reporting structures, we had already had a working relationship based on our HPV vaccination efforts, and we were able to truly expand that to include other vaccine-preventable cancer initiatives like hepatitis B vaccine. For social media, I think our graphics and our general campaign looked super sleek thanks to our access to an external marketing firm. However, due to working with an outside contractor, as I'm sure many of you can relate to, we did experience some delays to our timeline. Another thing that was kind of interesting related to our social media campaign is in the cancer world, we rarely get any kind of negative engagement on our social media pages and posts. However, with our new increased focus on vaccination, both hepatitis B and HPV vaccination, we did have some negative comments related to the need for vaccines in general, why administer Hep B at birth, and really needing to focus on risky behaviors in youth instead of on these vaccinations. However, I think in general, our social media campaign went really well, and our presentations to healthcare providers at booster shots were well received. Lastly, some lessons learned before I turn it back over to Banush. We were able to identify existing opportunities to engage healthcare providers. So the immunization program does these booster shots sessions every fall. Vaccine providers expect them, have them on their calendar, and we were able to kind of tap into this existing educational resource. And for those of you who are healthcare providers, you know how important it is to get information to folks in a venue that they're already participating. So it's not one additional activity or thing they need to read. Social media is also a resource-efficient way to disseminate cancer prevention messages. So we're truly able to reach a lot of people. Even with our limited resources, we're truly able to kind of get that wide reach, seeing as how we got up to 40,000 folks through this campaign. However, it is important to fully understand not only your individual capacity for posting on social media, but all the different limitations for social media evaluation. So you can get some great information about reach, but with any social media initiative, it's really hard to be able to track what happened next. So that is what I have here in Idaho. I know that we're taking questions at the end, but our project here with the Comprehensive Cancer Control Program in Idaho, I think went really well and provided a great template for doing other, not only hepatitis B and vaccination and liver cancer prevention efforts, but really in general, this is a great template to use to focus on any educational campaign using social media and provider education. So I'm going to turn it back over to Danush to kind of give you a little bit of background and then
Charlene,
wrap up.
Will you be able to drive the slides for me?
You want me to?
Yeah.
Okay.
While we're transitioning, thank you so much, Charlene. That was really interesting data that you found. And we do have questions that are coming in, and we will read them out after Jacki's remarks. While we're transitioning over, just another reminder again for everyone, if you haven't sent in any questions, please feel free to do so at any time. Just type them into the chat box, and we are reading them as they come in. Right. Danush, we're right back to where you left off.
Okay. Charlene, you can go to the next slide. Did you hear me cover who it primarily is affecting?
Yes. Yep. So I'm going to go to rates of new cancers by age group.
Okay. And so with respect to looking at the age group, we are seeing higher rates in those that are aged 55 to 84 years. We can go to the next slide. So as far as the major contributors, so what we're seeing here are 4 key contributors, one being the high prevalence of chronic hepatitis C virus infection among baby boomers, so those were born between 1945 and 1965, being the major factor contributing to the increase in hepatocellular carcinoma, which is the most common type of liver cancer. And then 3 other risk factors for primary liver cancer. The first is obesity and type 2 diabetes as they relate to non-alcoholic fatty liver disease. The second is the chronic infection with Hep B virus. And then the third is alcohol cirrhosis. About a month or 2 ago, the CDC's MMWR, which is our weekly morbidity and mortality report, published 6 alcohol-related cancers, and those were the mouth and throat, larynx, esophagus, colon and rectum, breast, as well as liver cancer. Next slide, please. So how did CDC get involved? Back in 2010, the National Academy Report released a report on hepatitis and liver cancer, which is a national strategy for the prevention and control of hepatitis B and C. And a key barrier to HBV and HCV prevention and control efforts that they included and reported in this report was the lack of knowledge and awareness about chronic viral hepatitis, not only among healthcare providers, but at-risk populations as well as the public. So in this report, next slide, they provided recommendations for improving the prevention and control of chronic hepatitis B virus and hepatitis C virus, and these are the 4 recommendations. One was to improve viral hepatitis surveillance. The second recommendation was to improve provider and community education to increase knowledge and awareness of HBV and HCV. The third is increased support for vaccine-based strategies, so immunization to eliminate the hepatitis B virus. As we all know, there is a vaccine for Hep B. And then fourth is the integration and enhancement of viral hepatitis services, including risk factor screening and testing. Next slide, please. And so this is where the National Comprehensive Cancer Control Programs and our partners step in and shine. And so really the idea here is how can we leverage our mandate of promoting vaccination, and next slide, supporting healthy lifestyle choices, education, and outreach to encourage screening, supporting patient navigators, working with health systems, surveillance, and even developing educational programs for cancer survivors. And so really, how can we utilize what our mission and vision of our program is to implement some of these interventions? And so a little bit of background on the Comprehensive Cancer Control Program. It was established in 1998 with the goal of providing the funding, guidance, and technical assistance that programs use to design and implement impactful, strategic, as well as sustainable plans to prevent and control cancer. So currently we have 69 cancer plans that have been created and updated since 1998. There are over 98,000 people that are involved in coalitions since this establishment, and the national program currently supports all 50 states and DC, 7 U.S. associated Pacific Islands and territories, as well as 8 tribes and territories, tribal organizations. Next slide, please. So a little bit of background for those who are not familiar with the program. As I mentioned, it was established in 1998, and we supported 6 programs with 6 cancer control plans that were developed. In 2000, the National Partnership provided the first Leadership Training Institute. And then a year later, in 2001, there were 14 additional programs that were funded to plan and implement comprehensive cancer control activities. A year later, we had 28 additional programs that were funded. Next slide, please. 2003, the Cancer Control Planet website was launched. And then by 2005, so very quickly, you can see all 50 states were funded for CCC activities, which is the Comprehensive Cancer Control Activities. That same year, we also released a special issue in Cancer Causes and Control, which published comprehensive cancer approaches to cancer control. That same year, the National Cancer Survivorship Resource Center was also created. Next slide, please. In 2010, this is also when the National Academy's report was released with respect to hepatitis and liver cancer. We also had 6 priorities that were established. In 2008, I did skip this, but we celebrate our 10th anniversary, and there was an article that was published in Preventing Chronic Disease. And then just a couple years ago, in 2017, CDC provides support to 66 programs, and we're in our 4th nationwide funding opportunity. In 2018, so just last year, we had our 20th anniversary celebration. We welcomed almost 200 individuals to Atlanta to celebrate 20 years of the national program's existence. The attendees included program awardees from the health departments, from our partners, organizations, as well as our cancer coalitions across the country, including CDC staff. And so here's some highlights from the celebration. Next slide, please. So coalitions are our backbone. Of the coalitions in the U.S., 72, this is a little bit of a snapshot of what our coalition entails. So 72% include partners in local, state, or national government. 94% include members from professional organizations. 76% are people who make laws or local policies. 95% include members from colleges or hospitals. 85% include people from local businesses. And 100% are public health program workers. Every coalition creates a plan to guide activities by looking at the common types of cancers that are unique in their community and really looking at the highest burden, and develop strategies that are incorporated into their CCC plans to help prevent and control those high burden cancers. And so they look at the risks that can lead to cancer. As I mentioned earlier, CDC supports 50 states and DC, as well as 7 PIJs and 8 tribes and tribal organizations. With respect to our priorities, CDC has 6 priorities. These were established back in 2010. 3 of them are what we call our core priorities, and then 3 cross-cutting priorities. So the 3 core priorities, one is to stress primary prevention or making healthy choices to stop cancer before it starts. The second is to help people find cancer early by getting them screened at the right time. And then the third is to support people that are diagnosed with cancers, so our survivors, and providing them treatment and beyond. In addition, we have the 3 cross-cutting priorities, and I'll go into that. And when we just quickly look into, very briefly, the 3 core priorities, what are we doing in the areas of primary prevention? So we can prevent cancer by providing vaccines that can prevent cancer. So examples are the HPV vaccine or the Hepatitis B vaccine. We can support environmental approaches that make healthy choices easier where we live and where we play. So an example here would be looking at our smoke-free policies, and then really empowering and educating people to make healthy lifestyle choices. And this relates to, and here are a couple of examples, tobacco use, nutrition, physical activity. When looking at our second core priority, promoting early detection and treatment of cancer, these are examples of activities that promote some of the work we do in this priority. So providing education and working on community outreach activities to really encourage screening. We find ways to support patient navigators and community health workers to really help remove the barriers to accessing cancer information, service, and treatment, and really working with our partners with health systems to improve the quality of the services. And lastly, supporting cancer survivors. And so we really focus on addressing the needs of cancer survivors and their caregivers by using surveillance to routinely assess the needs of cancer survivors, by delivering educational programs to help survivors, their caregivers, and providers make informed decisions, working with patient navigation systems to really optimize the treatment and care, and then looking at policies and systems change to improve access to care and other cancer resources and services. And then, as I mentioned, there's 3 cross-cutting priorities. So PSE, which is policy, systems, and environmental approaches. We're always doing work around this area. We're looking at health equity across the 3 core areas. So really looking at training, maintaining culturally competent workforce, including the patient navigators, promoting equitable access to the resources. And then our last cross-cutting priority is program evaluation. And then Charlene did mention really within some of the work they do, how they evaluate some of the work that they do to help inform some of the future work and help drive the public health decision-making and identify, again, what works and where we need resources and where are the gaps. Next slide, please. I also want to mention the CCC National Partnership. So while the states and territories and tribes have coalitions as their backbone, there's also a national group working to strengthen efforts across the country. So CDC is one of 18 members within the Comprehensive Cancer Control National Partnership. And the purpose or mission of this partnership is to assist the coalitions in developing and implementing and evaluating their plans at the state, tribe, and territory and Pacific Islander jurisdiction and local levels. Next slide, please. So, as I mentioned, with respect to liver cancer prevention and the National Comprehensive Cancer Control Program, in 2010, the National Academy report was released, and at that same year, as well as in 2015, CDC conducted focus reviews of our program awardees' plans to identify goals and strategies and activities related to liver cancer prevention. And what we found was that most of our plans did not address this connection between hepatitis B virus and hepatitis C virus infections and liver cancer. Only a few plans even mentioned any type of prevention activities to reduce the burden of liver cancer. Those with a large Asian Pacific Islander population were more commonly reporting the need to address primary liver cancer, and some plans did target specific populations, including the American Indian and Alaska Native population. So we knew that there was a lot of work that needed to be done in this area. Next slide, please. And so with us back in 2015, we launched this study, and phase 1 of this project was to develop a promising strategies document and supplement the 2015 review of the CCC plans. And what we did is we conducted a review not only of the CCC plans, but published literature to identify additional liver cancer prevention strategies related to hepatitis B virus and hepatitis C virus that could potentially be implemented by our awardees and the coalitions and their partners. So the strategies were then identified were organized by the 2010 Academy's report, and those are the 4 recommendations that I earlier mentioned with respect to surveillance and immunization and improved viral hepatitis and improved knowledge and awareness. Next slide, please. And so this paper was published in Cancer Causes and Control in 2018, and so you were able to access this paper, which incorporates published literature as well as some of the work of the CCC plans. We also developed a liver cancer prevention, putting strategies into action, call to action report that is also available, and we're happy to share this action plan as well for those who are interested in wanting to do some work around liver cancer implementation of strategies. Next slide, please. And then this really sets us up for the presentation that Charlene gave. And so back in May of 2017 through April of 2018, 2 comp cancer programs worked in partnership with CDC to plan and implement hepatitis B and hepatitis C related liver cancer prevention activities that aligned with the National Academy's 2010 report. And really the purpose of their activities was to increase awareness and knowledge among healthcare providers, among public health professionals, and community coalition members about the need to address viral hepatitis as a key risk factor for liver cancer, as much of our population is not aware of this connection. And the outcome was to identify promising strategies for liver cancer prevention that could be adopted and implemented across all of our comp cancer programs. So Cherokee Nation, along with Idaho, were 2 programs that were recruited into this project to implement interventions. Next slide, please. And I'll end with some of the steps that these 2 programs put into place for preventing their liver cancer prevention strategies into action. So as Charlene mentioned, and Cherokee Nation was another program that was involved, first they assessed the burden and they defined their need. As she mentioned, Hep B vaccination was an area that they really wanted to work towards and improve their vaccination rates. So that's the area and the strategies that they decided to work towards. And so step 2 was to choose the relevant strategy, and that's what they did. 3 was identifying a key partner that would be needed to implement the strategy successfully, and Charlene mentioned the partnerships that she engaged with to roll out and implement the strategy. 4 was the implementation piece, and then 5 that she discussed was measuring the success through evaluation. And the paper has now been cleared at CDC and will be submitted to a journal for publication. So all of the data that she presented will hopefully soon be published in a journal. Kate, we can turn it over to you.
Great. Thank you, Banush, for that wonderful presentation. It is actually really wonderful to see the cross-CDC collaboration when it comes to liver cancer and viral hepatitis. So I'd now like to turn it over to our patient advocate, Mr. Jacki Chen, for sharing to share his story in person and for your remarks. Jacki?
Hi. Hello. Hi, everyone. Thanks, Kate, and the organizer for inviting me to participate here. My name is Jacki, and I'm happy to be here sharing my personal story. As stated, my wife and I are living healthy and taking the Hep B medication continuously. We have regular blood tests twice a year and ultrasound exam once a year. In fact, we just did our exam last week and everything okay. We are very happy about that. The Hep B virus continues to be undetectable and all liver enzymes are within the normal range. All are killer-free from hepatitis B. So the reason I'm here is to share my personal experience of living with the virus for my whole life. I hope to help others to prevent Hep B infection and to deal with the disease. I'm currently actually a senior professor at a medical school. I've been teaching viral hepatitis for the past 15 years. I'm a molecular biologist in training, and I've done cancer research for the past 35 years. I graduated from National Taiwan University back in 1985. At that time, hepatitis B was a very scary thing there, as many classmates fell ill because of hepatitis. I was lucky that I never had any symptoms, but I was unaware that I also had the virus. The prevalence rate of Hep B infection in Taiwan at that time was as high as 20%. And Taiwan, as you know, was the first country to implement a nationwide Hep B vaccination program for all newborn back in 1984. For those born After 1984, the rate of HBV infection dropped dramatically due to successful vaccination that blocks vertical transmission. However, for us born before 1984 or age above 35, 1 out of 5 are carrying the virus, almost all for lifelong. My brother's diagnosis was shocking for all of us because he was only about 35 years old when he was diagnosed of liver cirrhosis and liver cancer. He had liver cancer and liver cirrhosis, and those are caused by hepatitis B. Luckily, his doctor put him on antiviral immediately and treated his liver cancer aggressively. He went through liver surgery that removed most of his liver, followed by several radiofrequency ablation, alcohol injection, chemoembolization therapies. He was also treated for liver cirrhosis-induced portal hypertension and did preventive vein ligation several times for esophageal viruses. Luckily, his cancer cells didn't spread out of the liver, and he is now free of the cancer for the past about 10 years. Although I heard about Hep B since college, it never occurred to me to check my own status. After my brother's diagnosis, I worried and eventually found out that not just me, but many family members and relatives are all Hep B positive. I had a very good doctor at Scripps Research Institute. They were doing clinical research at that time, and I was actually in trial, but didn't start the trial because of my mother's illness at that time. Instead, I focused on work and only monitor my status when I had time, and 10 years passed very quickly, and my liver enzymes were constantly elevated, and I had discomfort at my upper right abdomen area frequently. Eventually, I was so tired of the virus, I met a really good doctor, Dr. Ronald Nahas. He started me on Hep B antiviral in 2008. At that time, I already had severe fibrosis with active hepatitis. I've been taking the medication since then, and luckily, my liver fibrosis didn't progress further. I know that I'm still carrying the higher risk of liver cancer than those who were never exposed to the virus. So my wife also have the Hep B. Luckily, it was the last severe form of Hep B, the genotype B, my genotype C. If I can advance the slide. She had normal liver enzyme level and low viral load. However, we decided to ensure that the virus will not have a chance to be transmitted to our kids. My wife was treated with tenofovir during the last 3 months of her pregnancy back in 2012. It was still not a standard recommendation. We calculated the kinetic viral response to tenofovir and treated her for the shortest duration to ensure that the virus is undetectable at the time of delivery. Everything went smoothly. Our son was born in September 2012, and he was vaccinated within 2 hours after delivery with the first burst dose of Hep B vaccine plus 1 dose of Hep B immunoglobulin. This was followed by the second dose of Hep B vaccine at 1 month and the third dose of vaccine at 6 months. My son is now free of Hep B and is also immune to the virus. My brother is a liver cancer survivor. However, like many people, he made some mistake at the beginning. He tried many herbal medications to treat his liver condition. The situation only got worse until he had severe cirrhosis with GI bleeding and eventually liver cancer. He was bred and with love and support from the whole family. If it wasn't because of his diagnosis, I would probably never check my Hep B status and probably won't know it until it was too late. With this personal experience and training, we gathered several local volunteers in Taiwan and started to help more people. We set up a non-for-profit civil society organization called Taiwan Hepatitis Information and Care Association, or CICA in short. We gather regularly to share information and support each other. This lucky liver is our logo, and we love it. Next slide. Catherine, okay. So CICA Taiwan now is also a voting member of the Hepatitis Alliance. And the next slide is our local Taiwanese Facebook group. We have about 10,000 members now, just for people from Taiwan and a few other from several Chinese-speaking countries around Taiwan. It's a very active group. We share information and help answering questions almost every day. We also just did our first fundraising 2 weeks ago to help a single mother. She had an emergency surgery due to massive GI bleeding caused by severe liver cirrhosis, which almost took her life. Thanks to many patients and members, we had about 100 people donated and reached our goal quickly within 12 hours. I also run an international hepatitis treatment without border patient group. Members in this group are from all over the world. The last slide, the next one, and the next one is just some take-home messages that I hope you can help to spread the word. If you don't know the status, get tested. If you are surface antigen positive, you monitor regularly. You can have acute hepatitis and won't notice it until liver failure. Once you are tired of the virus, get treated. Current medications are very safe and highly effective, very low resistance rate. You can take it long-term to control the virus. You can start treatment early all day. There's no best time to start, and it is never too late to start. Protect your next generation. Antiviral treatment during pregnancy, vaccination of all newborn, plus HB immunoglobulin if necessary. If liver cancer occurs, don't give up. There are many effective ways to manage liver cancer. Liver cancer is curable, but don't wait. Most importantly, liver cancer is preventable. Cure the virus. Prevent hepatitis. Thank you all, and I'm happy to take any questions.
Wonderful. Thank you so much, Jacki, for sharing your story with all of us and spreading the message globally.
Thank you.
We're very happy that it is a happy ending message and that you, your brother, and your entire family are healthy and well. So on the next slide, we'll start our Q&A session. Please feel free to continue sending in your questions. And we did have a few come in, and I'm going to read them out. So our first question is for Charlene. You had talked about the social media strategy, and the question is, was there any social media comments from anti-vaccination groups around hesitancy, and how did you address them?
Yes, yeah, great question. So I kind of briefly mentioned that usually we don't get any negative engagements on our cancer social media pages, but with our new focus on cancer prevention vaccines like HPV and hepatitis B vaccines, we have definitely caught the eye of anti-vaccination groups. And for any of you who have encountered these groups before, you know they are very loud and very well organized. So our strategy for addressing their social media comments was, if we're able to, if the comment is somehow, related to misstating scientific facts or, saying genuinely inaccurate things that are, not related to specific, individual experiences, we have responded back with, thanks for your comment. Here's where you can go to get information about adverse reactions, or this is why this vaccine is safe, or here's what the data says. When the comments get into, personal opinions or patient experiences, we have chosen as a program to not poke the bear. So we do not engage in a back and forth, battle of the facts or experiences with folks who are providing those types of comments. We just kind of let them exist. If they turn into something that is truly negative or mean or disrespectful, we either hide those comments or delete the comments from our page. But we do not engage in a back and forth debate with folks from anti-vaccination groups who are making those types of comments. So there isn't really a hard and fast algorithm on how we decide, whether or not to respond, hide, or delete. It's kind of a gut feeling based on what that comment looks like, but those are the options that we use. Great question.
And a follow-up to that is around your evaluation is how did you measure the impact of social media impressions and interactions and KAB of immunization? Were there any specific metrics that you used to assess that project?
Yeah, so
behavior.
Perfect. Yeah, so for our project, we specifically focused on reach. So it is very challenging to assess like knowledge, attitudes, beliefs, or actions through a social media campaign. We primarily focused on how many folks saw this post or engaged with this post in whatever way. When we started this project, we had initially hoped to do a knowledge and awareness assessment or survey as part of our efforts, but due to our own internal capacity as well as our capacity within our Facebook platform, we weren't quite able to figure out the best way to do that knowledge and attitudes assessment, but it's definitely something to consider as part of any of our work moving forward. So it's kind of a non-answer answer, but hopefully it's helpful.
Yeah. It is, thank you. So one more question for Banush and then one more for Jacki. So Banush, someone is wondering, how do they access the Survivorship Resource Center?
Oh, sure. And we're actually I'm happy to share that with you, Kate, as far as how we can get that and disseminate not only that, but our action plan that was developed as well is located on our website, as well as our promising practices paper. So I'm more than happy to share the resources with you, Kate, and if you want to disseminate that out.
Perfect. Thank you. I will do that. And we will share these presentations on our website and send around the link. And then for Jacki, so we do have individuals who are personally affected by as well by hepatitis B who are joining this webinar. And do you have any advice similar to how you're getting involved in how they can be part of supporting and fighting for prevention, for a cure, for treatment of hepatitis B and liver cancer?
For themselves, the best way to start would be to join the patient group on a Facebook group, for example, and then you can communicate with any of us privately, or you can post it publicly, and anyone who are interested to answer your question or who have more information will share those information. That's the best way, is they share information publicly, and in that way that everyone can see it. Then if there's anything that that you need to be cautious about, then we can tell you what to watch for. So I think the best strategy is to share some of your questions publicly, and in that way then you can get the feedback from many people, and then you can make your own judgment.
Thank you. All right, so we have come to the conclusion of this webinar. On the next slide, I wanted to share our contact information. Any follow-up questions that you have in general about hepatitis B and or liver cancer, any questions that you have that we did not have time to answer, please feel free to email us at connect@hepunited.org, and I'll be sure to get back to you and pass them on to our panelists. And I also wanted to thank all of our speakers, Banush Momin, Charlene Carrio, and Jacki Chen. Thank you so much for sharing your wonderful work and your story with us today. Thank you everyone for participating. We hope that you found it informative and valuable to your work. And lastly, I'd like to invite you to complete an online evaluation of the webinar, provide your feedback about your participation, and apologies again for the technical difficulties. And hope you can join us next month on our November webinar. Thank you again, everyone, and have a great day.
Thank you.
Thank you.
Have a great day.
Bye-bye.